Okay, our next speaker is Lisa Brents. Lisa defended her dissertation in December, and she has been studying synthetic cannabinoids and their use as medication. So let's welcome Lisa.
Like Ann said, I studied synthetic cannabinoids as my dissertation project, and those are substances that are found in K2 and spice that are used as marijuana substitutes. I'm not going to be talking about that today. I'm going to be talking more about those substances aren't used medicinally; they're abused. My talk today is going to be more about cannabinoids used as medicine. And you notice I don't say cannabis as medicine. This is much more broad than just cannabis, and hopefully that'll be clear, a little bit more clear here in just a moment. So to let you know where we're going, first I'm going to talk about cannabis and what is in it. A little bit of history about how it's been used for thousands of years. I'll go over some generals about cannabinoid biology and what actually happens whenever someone uses marijuana or uses the cannabinoids. I'll talk about some medical indications and current medical investigations that are going on regarding this class of substances. I'll name some medicinal cannabinoids that are actually used as medicines that are approved on the market currently. And I'll also share a few comments about legalization and what's a biological perspective on legalization of cannabis. So first off, most everybody knows what marijuana is. As you can see from this picture, this is what the leaves look like. This bottom picture is a picture of the female part of the plant, which is what is actually abused. And the top right-hand picture is a close-up of some of the structures on the female part of the plant. They're called trichomes, and they contain hundreds of chemicals. In particular, they contain over 60 cannabinoids. And cannabinoids, one definition of cannabinoids is that they are chemicals that are unique to the plant cannabis. Another definition is that they are chemicals that are structurally similar to substances found uniquely in cannabis. Or they can also be drugs that act similarly, that have similar pharmacological actions as cannabinoids found in cannabis. So cannabis contains over 60 cannabinoids, including delta-9-THC, that's delta-9-tetrahydrocannabinol, and that's the most popular, most well-known cannabinoid. It's the psychoactive component of marijuana. So that's actually what makes you high, it increases mood, increases feelings of well-being and relaxation, alters perception of space and time. That's not the only cannabinoid in these plants. Like I said, there's also cannabidiol and delta-9-tetrahydrocannabivarin. So here's a list of several of the main cannabinoids found in cannabis. And they have several known variants, as you can see here. So, like I said in the outline, people have been using cannabis for thousands of years. For instance, in China, around BC 4000, the Chinese cultivated cannabis for fibers that they used to make strings, ropes, textiles, or even paper. And cannabis has been used, was recorded as a drug in their pharmacopoeia as early as 2700 BC. Some of the indications that cannabis was used for in China at this time include rheumatic pain, intestinal constipation, disorders of the female reproductive system, malaria, as well as others. Cannabis was also used in conjunction with wine as an anesthetic for surgery by Hu Tuo, who is considered the father of Chinese surgery. The way that the Chinese used cannabis, it seems that their preparation may have not contained may have contained a very low concentration of delta-9 THC, the psychoactive cannabinoid. And modern science has shown that other components, such as gamma linoleic acid, that are found in cannabis that the Chinese were probably using in those preparations, also have medical value. In India, cannabis was used around this time too, actually around 1000 BC, and it was used as an analgesic for neuralgia, headache, toothache, as well as an anticonvulsant, hypnotic tranquilizer, antibiotic, antiparasitic, an aphrodisiac or an anaphrodisiac. So I don't know how that works. Either way, an antitussive and an expectorant. So as I'm listing these indications, they sound kind of familiar, right? So these ancient people were using the cannabis for some of the same things that we find it's useful for too. Let's see. So that was before the Christian era, and within the Christian era, since, let's see. Actually, let's skip forward to modern Western medicine. In the 19th and 20th century, let me move forward here. These two guys played a role in publishing some of the first scientific studies, I guess you'd say, or scientific works regarding cannabis. On the left is O'Shaughnessy, who is a Irish physician. In his book on the preparations of Indian hemp or ganja, he studied the literature on the plant, and he also he actually did scientific studies, evaluated the toxicity of the substance in animals, and later he tested its effects on patients. So these are actual scientific studies that were done in the 1800s. He describes cannabis as being used for rheumatism, convulsions, and for muscular spasms of tinnitus and rabies. So now we see, and I'll kind of get ahead of myself for just a second, whenever I say that they use them for muscular spasms, cannabinoids are also being studied currently for spasms that are caused by multiple sclerosis. So you see that they were using them for the same indications. The gentleman on the right is Jacques-Joseph Moreau, and he was a French psychiatrist, and he did some systematic studies. He first experimented on himself and then other patients in psychiatry, and found that these were very good substances for psychiatric patients as well. So around the turn of the 18th century, over 100 scientific publications were published, and this brought on a use of cannabis tinctures and extracts and that were used for many different indications. And you can see in this publication, Saja's Analytical Encyclopedia of Practical Medicine, that was published in 1924, cannabis was used as a sedative, hypnotic, and there's a whole list of indications, including insomnia, senile insomnia, melancholia, mania, delirium tremens, so that's withdrawals from alcohol. And I won't list all of them, but it's also used as, they also listed as an analgesic for a whole list of indications, as well as other miscellaneous uses for appetite and digestion. This is interesting, pronounce anorexia following exhausting diseases. And the approved cannabinoids, and I'll get ahead of myself again for just a moment, the cannabinoids that are approved by the FDA are for that exact indication in cancer and AIDS patients. So, why did the use of cannabis decrease, the use of cannabis as a medicinal substance? And one of the major causes was the Marijuana Tax Act of 1937. And in this act, the federal government placed a tax that anybody who was going to use this plant for medicinal purposes had to pay $1 an ounce. If you wanted to use it for non-medicinal purposes, you had to pay $100 an ounce. If you did not pay this tax, it could result in a fine of $2 and/or 5 years in prison. So as you can imagine, this really put a strain on the use of marijuana. And also at the same time, other medicines were being developed. Aspirin began to be used. Hypodermic needles were developed, and so people could inject morphine for analgesia. Vaccines were becoming available, so people didn't use them for, didn't use cannabis for things like tetanus or other infectious diseases anymore. So another thing that stifled marijuana was the Controlled Substances Act of 1970, and this is where the schedule classifications of drugs came from this act. And marijuana was placed in the most restricted category. It was classified as a Substance 1. A Schedule 1 substance. And the definition of Schedule 1 substance is are drugs that have a high potential for abuse, no currently accepted medical use for treatment in the United States, and a lack of accepted safety. So that seems a little odd, considering that throughout time, ancient people had used, in various different locations in the world, had been using these for overlapping or very similar indications. So in 1964, this gentleman right here, Dr. Raphael Mechoulam, he is a pain researcher at Hebrew University in Jerusalem. He isolated and synthesized the psychoactive component of marijuana, delta-9-THC. As you can see, this is the structure for delta-9-THC. This is from his original publication reporting this discovery. And you can see at the bottom, the reason why he knew it worked is because it showed strong activity in the ataxia test. And I don't know exactly what the ataxia test is. I just guess that makes them high, I guess. And
ataxia would mean that they're falling over. So
right.
Something to do with whether they got balance or not.
Right. So they lose their balance or they're not able to stand. And so they followed that up with a full characterization, in vivo characterization afterwards, and determined that that's the case. So that was in 1964, and over the following couple of decades, scientists were able to determine the endogenous systems upon which delta-9-THC acts. For instance, they figured out that there are they figured out the major receptors upon which cannabinoids act. Here's CB1 and CB2, and they're G-protein coupled receptors, kind of like the receptor that Martin mentioned in his talk, the alpha-2 adrenoceptor. They're in the same class, and G-protein coupled receptors are a major class of receptors. And these are just intracellular proteins upon which drugs will bind and elicit actions within the cell that alter the function of the cell. So CB1 is expressed in a high density in the brain, and it mediates the psychoactive effects of marijuana. It's also expressed throughout the body, and I think I'll talk more about that in just a moment. CB2 is known more for its effects on the immune system. It's expressed in macrophages, monocytes, other cells of the immune system, and that's possibly where the anti-inflammatory effects of cannabinoids are mediated. So as you can see in my note to the side, the endocannabinoid system, it's the endogenous system that modulates mood. It's not these are not neurotransmitters. These systems, the ligands, the endogenous ligands for these systems are not neurotransmitters, they're neuromodulators, and they modulate other systems that are involved in mood and stress response, immune function, inflammation, appetite. Energy homeostasis are how energy is processed and stored. Also involved in fertility and fetal neurodevelopment and bone homeostasis. So you don't really think about all these things when you think about the use of cannabis, that the use of cannabis can alter these various processes. To talk a little bit more about the endocannabinoid system, whenever you have exogenous, or substances that you put in your body. Whenever you have exogenous systems that act on endogenous proteins, it's very likely that there are also endogenous chemicals that are made by the body and also act on those same proteins. So around the time that they found these receptors, 2 endogenous chemicals were found, and they're called anandamide, which is not pictured in this illustration, but I have its structure right here. That's anandamide, and then 2-AG, which is also in this actually in this picture, and there's its structure. And they bind to the receptor and they act as agonists, which I'll explain what an agonist is in just a second. You also have as part of the system, the enzymes that degrade these endogenous cannabinoids called MAG lipase and FA. So all of these things that I'm talking about, they represent pharmacological targets that scientists can exploit, can target and exploit to alter these processes that we see here. So I think that's enough about that. So a little bit of basic pharmacology. Like I said, these ligands will bind to a receptor, to a protein, and cause an effect. And this is an illustration, a general illustration of how this works. You see here represents basal activity, and an agonist, either a partial or a full agonist, will increase the effect that you're looking at. And you can see a full agonist maximally increases that effect in this system, while a partial agonist does so partially. A neutral antagonist won't have any effect. It'll bind, so in that way it will prevent the binding of other ligands, but it itself has no effect. And you also have inverse agonists that actually decrease whatever the activity of whatever effect you're looking at. So we have efficacy, and that's that's the magnitude of effect. And we also have potency, which is how much of the drug that that must be used in order to get an effect. So if I use those terms, that's what I mean. Let's see here, and there's a certain drug that I'll talk about in just a moment where this will be a little bit more important. This will help you understand that drug a little better. So what are the things that people use cannabinoids for, and what are some of the current investigations? And like we said before, appetite stimulation, particularly in AIDS patients and cancer patients that have wasting diseases. Also antiemetics in cancer patients. Analgesia, anticonvulsant, anti-cancer in multiple sclerosis, Huntington's disease, Lou Gehrig's disease, and as a neuroprotectant in hypoxia and ischemic injury. And I'm sure there's several more, but these are some of the ones that I found whenever I went on a quick search. So to go along with Martin's talk, some people propose looking at the effectiveness of cannabinoids for irritable bowel syndrome, irritable bowel disease. And the hypothesis is that the endocannabinoid, and this is very small, please don't try to read all that, I just want to bring up the important parts of that. The endocannabinoid system is involved in the regulations of several gastrointestinal functions, such as motility, sensation, and secretion under both physiological and pathophysiological conditions. And so those are some of the problems that you see. Those are some of the things that are affected in IBS. So it's hypothesized that perhaps manipulation of the cannabinoid system may improve that. I have 2 studies that they looked at in people, and in this first one it does not appear that delta-9 THC actually affects visceral sensitivity. To do this, they had 10 IBS and 12 healthy patients. They underwent a barostat rectal sensitivity test, either under the effect of placebo, delta-9 THC, 2 different doses. Excuse me. As far as the results go, there was no decrease in the sensitivity between either the patients or the healthy volunteers, they did report increased awareness of the surroundings, lightheadedness, and sleepiness. So it looks like in this particular study there was no effect of delta-9 THC in improving or decreasing visceral sensitivity. So this study looked at pharmacodynamic and pharmacogenetics, that is how are certain genes altered by treating with a cannabinoid agonist, dronabinol, which is simply delta-9 THC, or versus placebo. And I think in this study, they did not detect, whenever you look at the clinical effects of gut transit, they did not see any effect compared to placebo in these patients. But this is actually I guess you'd consider it a retrospective survey study of that was conducted of people who have either ulcerative colitis or Crohn's disease, which, as Martin told us, does fall under the umbrella of IBD, right? Or is it called IBS? IBD. And they asked these people about their cannabis use, and based on this survey, it looks like people find some sort of relief. So they use cannabis particularly for the pain associated with IBD. So in the past 10 years, there have only been about 18 studies of cannabinoids in IBD, and most of those are reviews in which people were just kind of putting their ideas out there about it. It doesn't look like there's a lot of primary investigation, primary publications regarding cannabinoids and IBD. So now I just want to mention some of the medicines that are used, and in one of those studies, like we mentioned dronabinol, which the trademark name is Marinol, and it's simply delta-9 THC, whereas marijuana is a whole bunch of different chemicals. This is just delta-9 THC, and it's used for wasting and AIDS in cancer patients. And it's been FDA, and I should mention that while THC is Schedule 1, while marijuana is Schedule 1, Marinol was actually rescheduled as a Schedule 3 drug in 1999. So for similar indications, Sesamet or Nabilone is used for nausea and vomiting caused by cancer chemotherapy. I should also mention that these cannabinoids are used as kind of like a last effort. Whenever every other anti-emetic or anti-vomiting, anti-nausea medicine has failed for these patients, that's whenever you turn to cannabinoids. So this drug is simply an analog of delta-9 THC, so it has very similar effects. It's also an agonist at the CB1 and CB2 receptors. So they mention a potential for abuse of these substances, and that's something that people have studied and are looking for. But it appears that these substances aren't abused as like marijuana is. They also have a note about Sesamet can affect your mental state, so take it around an adult you trust. So these drugs have some pretty, they have side effects that have to be considered. So this is Sativex, also called nabiximols, and as you can see, this is in Spanish. Don't try to read it, or unless you want to, but I liked the picture because it shows a very important aspect of this drug, that it's an oromucosally administered drug, and part of the motivation for doing that is to decrease any kind of abuse liability, and it also promotes the absorption of these substances. And this drug is a little bit different from the others because it is a mix of extracts from marijuana. It's about a 1-to-1 mix of tetrahydrocannabinol of delta-9 THC and cannabidiol, which is a phytocannabinoid. It's a non-psychoactive cannabinoid that is under intense biomedical investigation because it appears to have some effects some beneficial effects in some patient populations. This drug is indicated for multiple sclerosis, spasticity, neuropathic pain, and overactive bladder. And I think these last three on the list are associated with multiple sclerosis. Right now, Sativex is also in phase 3 clinical trials for cancer pain. So this changes gears a little bit. This is Acomplia. This is also known as rimonabant. And remember I said earlier that the endocannabinoid system modulates appetite and it modulates energy homeostasis, or how energy is handled. So if you think about marijuana, people smoke marijuana and they get the munchies. It makes them hungry. They eat more. And so if you eat more, that's going to promote weight gain, right? Not only does activation of the endocannabinoid system promote an increase in feeding, hyperphagia, it also increases your fat storage. So it decreases your metabolism, your energy metabolism. So if you can block those effects, this results in a weight loss, and it also improves cardiometabolic measures of things that are often altered with or dysregulated in obesity, like blocking the endocannabinoid system will improve your HDL to LDL ratio. It'll also decrease your triglyceride levels. So yeah, I wanted to show this again right here, because so the synthetic cannabinoids that I study, they do this. And that's probably why, if you've heard me talk about synthetic cannabinoids, or you've heard anything about K2 or spice, that's probably why they're so dangerous, because they activate this system greatly. THC THC probably does something like this. Rimonabant does something between here and here. It blocks the activation of these receptors and may even decrease the activity of this receptor. So it's indicated for obesity, and it was on the market in the UK and was introduced to the FDA to be approved into the US market. But in clinical trials, they had an unacceptably high rate of depression and suicide ideation associated with this drug. And if you think about it, marijuana makes people happy and hungry, right? But if you block that, it's going to make them satiated but sad. So that's kind of a simplistic way that I think about this. So we don't have this available to us, but scientists are still doing. And actually, some of my dissertation work involved obesity and involved drugs that do similar things to this. So to me, that's an interesting thing, that way that you can exploit and manipulate the endocannabinoid system. So investigational medicinal cannabinoids, everybody's favorite, marijuana. That's why y'all all came out here today to hear about the marijuana. And so you go through the scientific literature and you don't see a lot about marijuana as a medicine. You see a lot about it as being abused, and some of the surveys and studies of that sort, but you don't really see studies where they have a mouse and they give it weed. They usually isolate some cannabinoid and then do studies with it. So it's kind of difficult for me to tell you what exactly is going on with marijuana itself as a medicine. But as you probably already know, there's a lot of controversy about marijuana. Some people say that it is, and I actually have some comments here. Jocelyn Elders, I'm sure most everybody knows Jocelyn Elders, has said, this is, and I'll paraphrase, it's been shown to relieve all of these problems, nausea, vomiting, and other symptoms a lot better than what she called more harsh drugs. And the response, not directly to her, but a counter point on that is that it's not, and there's other drugs that can be used. Kind of like what happened in the early 20th century, where other drugs were available, so people didn't use it. So a lot of people saying, folks should have access to it, and other people saying, no, it's dangerous, it causes harm to your brain and all this kind of stuff. So, and really there are a lot of adverse effects that scientists are working now to try to get around. For instance, some of the adverse effects that you see with dronabinol and the FDA-approved drugs are dizziness, drowsiness. People are not able to take these and then maintain their normal active lives. I think that may be why they're used as a last resort. So there's still some adverse effects associated with cannabis. So what about, and this is a growing field of interest in science, what about if we look at some of those other cannabinoids in marijuana that not just the one that everybody knows about that causes the psychoactivity? Do those have beneficial effects without the central effects? And so some of them are being investigated. One is cannabivarin as an anticonvulsant. Also, these investigators use a Sativex-like combination of phytocannabinoids so I'm guessing that's THC and cannabidiol in Huntington's disease. And cannabidiol here, that's something that's very important about phytocannabinoids in cannabis, is that they actually modulate the effects of THC. For instance, if you just infuse THC, inject THC in someone, the risk of showing psychotic symptoms is much higher than someone who's administered a mix of cannabinoids that are much more similar to those found in marijuana. So here, as you can see from this title, cannabidiol inhibits THC-elicited paranoid symptoms and hippocampal-dependent memory impairment. So why hesitate to legalize it? I mean, I know nobody in this room would actually ever say this or think this, but my response to this person is, what do you think about poison ivy? What do you think? But a lot of times people have seem to have this way of thinking that it's this magic substance and there's nothing bad with it. It's natural. So it's why restrict the use of it? So some thoughts about why we may not just want to jump into just it being available to anybody and everybody is that it's not been fully evaluated. And how do you standardize it? And I think that's one of the rules or one of the guidelines for a substance being a drug, is that it's standardized. You know exactly what you're getting with each dose, and it's very consistent. And you look at the variability of the substances that are found, and the variability in concentrations of the substances that are found in marijuana. And that seems to be a big task. It seems insurmountable to do that. And I think that's why scientists are looking at different extracts and looking at using these substances, but controlling the concentrations that you use of each one. Some of the adverse effects that occur with marijuana are some that people may not really think about, and it actually unmasks psychosis in predisposed individuals, and these people have a higher risk of schizophrenia when cannabis is used chronically. It has an abuse liability and a dependence phenomenon. I've heard people say, it's maybe psychologically dependent, but studies have shown that it actually has a physiological dependence phenomenon associated with it. That is, upon cessation from chronic use, people will experience symptoms such as problems with sleeping, problems with appetite, as a rebound from their chronic use. It's also been a recent study out late last year showed that it's linked to a lower IQ whenever it's used by adolescents, whenever those people are tested at a later age. It's also linked to neurocognitive deficits in I think at age 6, and also another study showed at age 14 when cannabis is used by a mother prenatally. So their children at age 6 and at age 14 have been shown to have neurocognitive deficits. And also it's associated with memory deficits. Maybe people don't realize it, but adolescents, because they're still undergoing neural structuring and they're still undergoing neurodevelopment, they're a very vulnerable population when it comes to marijuana use. If I'm 27, if I started using marijuana now, my risk of psychosis and my risk of dependence is much lower than a 15-year-old or a 16-year-old who starts using it. So adolescents are much more vulnerable to the adverse effects. So in summary for my talk, kind of the take-home points, marijuana actually contains hundreds of chemicals. 60 to 70 of them are unique to cannabis, and marijuana has been used by humans industrially, and I didn't really talk about the industrial or the religious aspects of marijuana use, but they've been used industrially, religiously, and medicinally for thousands of years. The effects of marijuana they're mediated by the endocannabinoid system, which has the job of maintaining a delicate balance of several different physiological processes. There's been a lot of scientific exploration of this system in the attempt to manipulate it to improve several different pathophysiological processes. There's also been the development of several different pharmaceutical agents, and there's also, as you already know, a huge controversy about trying to get it widely available as a medicine, or to just outright legalize it and tax it, and which makes a lot of sense too. Boy, I didn't finish that thought, did I? Caution should be taken in determining its legal status and its how it should be used as a medicine. Just like any other medicine that is out on the market, it should be tested thoroughly to make sure it's, considering that people have been using it for thousands of years and it is the most abused illicit drug in the world, it's pretty safe. It's pretty safe. It's not killing anybody. There's been no reported deaths with marijuana, but to determine the exact effects that are going on, there needs to be more analysis of what happens in these various systems. So if you guys have any questions, or if y'all like to have a discussion. Yes, sir.
When were the endoreceptors first found? I know that they didn't know what the internal mechanism was of that at all back in the 70s. When were they found?
I think the late 80s. You're talking about the cannabinoid receptors? Right. Late 80s, early 90s. So I think CB1 would have been found first, or otherwise they would have called it, they would have been called the flip-flops. But yeah, late 80s and early 90s.
Two sort of related questions, I guess. What's the evolutionary advantage for a plant to produce cannabinoids?
Okay.
And also, why would animals have a receptor that binds them?
That's pretty crazy, huh? These substances are secondary metabolites of cannabis. So I think I listed that ancient people use them as anti-parasitic agents. So these substances probably have some sort of protect the plant from insects or other parasites. So that's what I would think. And why do we have a receptor for those plants? That's right. Like he just said, why do we have a receptor for opioids that just happens to fit and to work? I don't know.
You use this word a couple of times, so I was wondering, can you define abuse the way you use it?
Abuse, as opposed to just use, or I think perhaps it's with the intent that there's not a medical intent, there's an intent for the psychotropic activity of the substance. Mr. Morgan?
Well, you were talking earlier about some of the, you were asking about like the binding sites for opioids. You have internal analogs to those. I mean, you have
Endorphins, yeah.
endorphins, and weren't you talking about some of the endogenous materials that normally bind at those sites?
Yeah, 2-AG and anandamide are
Right.
the two best known endocannabinoids is what they're called.
Right. So, you can have the plant producing those chemicals for its own reasons, but they just happen to resemble something that we produce for our bodies produce for a different reason.
By chance, you're saying?
And you have only a limited number of ways to rearrange carbon atoms, and
Yeah.
Do you know any more about the mechanism at work in the fetal neurodevelopment that you mentioned?
Not a lot, honestly. It may have something to do with pruning of neurons along the neurodevelopment, but
You mentioned that the two types of cannabinoids, one is synthetic and natural. Can you distinguish that or elaborate on that?
okay. So like I mentioned, cannabis produces about 60 to 70 secondary metabolites that are unique to that plant called cannabinoids. Synthetic cannabinoids are cannabinoids that we make, that scientists make, that they can be very similar in structure. In fact, probably the first synthetic cannabinoids were very similar in structure. As scientists knew more about the system and the receptors and how it works, they probably, using rational methods for the design of other substances, they made more synthetic cannabinoids that may actually have quite different structures. If you compare the structures of the natural cannabinoids and several of the synthetic cannabinoids, they're not very similar, but and that may explain why they have different effects after they bind to the receptor. And so that's the distinction is that synthetic cannabinoids are made by humans, often using a rational basis based on what we know about the receptor, how the receptor and the ligand fits together.
How many species are there of cannabis, do you know? I mean...
No.
One other question. When you had the legalization chart up there, I thought alcohol related to all of that. In other words, everything that you had on that list, if you just applied it to alcohol, it would basically be the same thing.
Yeah. I think alcohol to society probably has a harsher effect, and to the body, I bet. I think. But I agree.
Yes, just to follow up on cannabinoids, I suppose, are they naturally produced by the human body, and how would you classify that, and how could we probably increase the production
Yeah,
of
those are good
cannabinoids
questions.
in our natural system?
That's actually a pharmacological target. So I mentioned 2-AG and anandamide. Those are the kind of like endorphins are the endogenous opioids that the body produces. 2-AG and anandamide are the endogenous cannabinoids, and they're called endocannabinoids, and they're different from both the synthetic cannabinoids that you mentioned and the natural phytocannabinoids that are produced by marijuana. And going back to the pharmacological target, I didn't do a good job explaining the system, the picture of the system that I showed you, but there are enzymes that degrade those endocannabinoids. So they control the local level of endocannabinoids. And so if you can block the activity of those degrading enzymes, right, you can increase the levels of those endocannabinoids locally. And so that's something that maybe I should have mentioned in my presentation, to try to get around, that's actually that's something people are trying to do. They block those enzymes, increase the levels of endocannabinoids, and you aren't going to get the abuse issues that you're more prone to get with synthetics, or with, you're not going to get as rough of adverse effects with your own endogenous cannabinoids as you would with exogenously administered cannabinoids.
I was just going to say, I didn't know if anybody noticed, but in the paper this last week, someone did petition the Federal Drug Administration and the federal government to change the classification of marijuana, and they would not even consider it. Because just like what you said, they're saying that it has no medical value, there's no diseases that it'll treat, and he brought that up, that it's being used synthetically, and they would not even consider it. I mean, they completely they said no. Just wouldn't even consider his argument. Another thing I was going to mention, and you and I have talked about it before, I worked at Job Corps, and we had lots of students that had smoked marijuana since they were 6 and 7 years old. And one of the things about that is that it not only stunts them as far as their mental development, it also stunts them emotionally. They've always smoked marijuana to deal with any situation that they couldn't deal with. You get them in Job Corps, take all that away from them, and they have no way to deal with their emotions or problems, because that's how they always dealt with them. So it is a social problem still, even though it's illegal. It's still a social problem, because we have a whole group of people that's how they're dealing with their problems, and they also have uncles and aunts and mothers and fathers that have grown up smoking it, and they think it's okay for them for their children to smoke it.
Right, and I just thought while you were talking about that, how they have problems dealing with their emotions, how much of that is psychological and altered and shaped by their environment, and how much of it is actually the physiological effect of the drug on those very vulnerable developing systems. It's probably a little bit of both, but Yes, ma'am.
Well, I think that you sort of answered this a minute ago when you were talking about the endogenous cannabinoids.
Yeah.
Cannabinoids. But what do you see on the horizon as the direction that research will take in the next couple of years? And will it mostly be with the phytocannabinoids? Yes.
I think so.
Or the natural or the synthetic?
I think
cannabinoids.
A lot of I don't think so much the synthetic cannabinoids. I think the extracts, like I said before, one of the major problems with using marijuana, it obviously has some medicinal effects. But some of the problems are with standardization and knowing exactly what you get with the dose. But if you can extract some of first off, if you can figure out which phytocannabinoids are most beneficial and most efficacious and most ideal for different pathologies, you can develop extracts. Or you could even synthesize those, just like dronabinol is synthesized delta-9 THC. And then you wouldn't even have to mess with the plant at all. But I think that's the direction that the field is taking, to look at how these different phytocannabinoids interact with each other, interact with delta-9 THC, and how can you get the best out of those combinations, those extracts. Another, like the gentleman's question brought up a minute ago, is to block those degrading enzymes, those enzymes that degrade your natural cannabinoids. So that's another place that the field can go.
What you and Susan were talking about there has a serious problem with some of the interpretation, and I know some of those studies look like that too, in that they're confusing correlation and cause. They're saying that,
okay.
for example, you have teenagers smoking marijuana and then they have psychological problems. It's just as believable that these are people who have psychological problems and hence turn to some kind of drug. If you look at the same kind of correlation with alcohol, you find it in even bigger effects there. And there is a known way to look at what is the actual damage caused by the alcohol.
Right.
That has been studied well. I don't think there is this corresponding kind of thing with cannabinoids to have a known actual mechanism, or, for example, making somebody be psychotic. How about if people who are prone to psychosis simply turn to marijuana? That's just as believable. It's known, for example, that people who are prone to schizophrenia take to cigarettes as a way of self-medicating themselves. So.
Right, yeah, confounders definitely present a challenge to designing these studies. But I mean, I think that, I'd have to think about it for a minute, but that's the goal, to design these studies and to ask these questions in such ways they can be answered to get around those confounders.
Well, I mean, part of the way of getting around the ethical considerations, so you can't set up controlled experiments to do all this. Part of the way of getting around that is to find an actual physical mechanism, which, for example, they have done between nicotine and schizophrenia.
Okay.
If you know that, then you can say something definite about what causes what.
Got a lot of questions.
That's fun.
Are you coming down to the...
Yes.
I can if
Have you come across an article? I understand that there is a very sophisticated research going on in Israel. I think the government is the one sponsoring this as far as marijuana is concerned. What they're trying to do is they're trying to isolate certain negative effects like drowsiness and retain certain effects that are beneficial. Can you comment on that? Have you heard about that? This is something sponsored by the Israeli government.
I don't know specifically the study that you're describing, but that is generally a goal. And I didn't mention allosteric modulators. I don't know if I want to go into that, but these are drugs. These are substances that modulate, that alter the effect of another drug without themselves having a lot of effect. So you have a wider variety of effects. Depending on your allosteric modulator that's co-administered, you have a wider variety of effects that you can more or less tune the effects of the first drug. That's one thing. And if you go back to the phytocannabinoid story, that these non-psychoactive cannabinoids are also smoked whenever someone uses marijuana. They may also, like I mentioned before, using THC by itself has a higher risk of adverse effects, psychosis and such, than marijuana or than extracts that have these non-psychoactive. So even though these substances aren't psychoactive themselves, they're altering the psychoactivity or the effects of this active. Does that make any sense?
I was thinking more of like isolating certain components or chemicals within the cannabinoids or the marijuana.
That would, that would make sense.
Counteracting a different type of chemical to subdue the effects of negative effects. Also, I was wondering what mode was how did the older ancient times, how did they induce or imbibe marijuana? Was it through smoking, or did they chew it, or how was the new research?
It looks like some of them, like that picture I showed you that from ancient Egypt, it looks like some people actually smoked. The article that I had mentions the Chinese using it as a food, and some people use the oils, but I think those have a very low or have no concentration of delta-9 THC. So used as oils, the seeds were used as food, and I didn't mention this, but did I mention Herodotus and the historian? He reported that, who were they? This group of nomadic people that he was with, they actually burned cannabis at a funeral. And so they inhaled the vapors at this funeral for ritualistic and also euphoric effects, is what the article said. And this was corroborated by modern day archaeologists who actually found charred cannabis seeds in tombs where these funerals would take place. So people did smoke them in ritualistic ceremonies.
Yeah, I was wondering, now the binding sites for the endocannabinoid binding sites are they all on neurons? Are they in other tissues as well?
Other tissues, I didn't go into that. Liver, so a lot of the energy homeostatic effects are liver, you've got fat cells, you've got intestines, you've got bone. I mean, there's a lot of different tissues.
What tissues generate the endocannabinoids?
They're generated at the same location by the same types of cells onto which the receptors are located.
So they're not traveling a
No, they're
large time
synthesized on demand because they're lipids.
Okay.
They're very susceptible to degradation. They're synthesized on demand when the cell needs them, and used on demand right then. So they're not like hormones that are made in one place and are taken to another.
Anyone else?
One quick comment in response to his question. They were also used in India for a long time in butter. Using marijuana in butter was a very common way of ingestion.
Very cool. Thank you.
Thank you, Lisa.
Thank y'all. Y'all been fun. It's been good. Thank you.